Welcome to the second It's a Pain public engagement lecture, which is entitled Every Move You Make, the Normal Psychology of Chronic Pain. And it's going to be led by Professor Stephen Morley from the University of Leeds. My name is Joanna Quinlan, and I'm responsible for organising the lecture series from the NHS side, along with Nicola Massingham and Dr. Mel Davis. And we're part of a pain management team, and more widely than that, we're part of County Durham and Darlington NHS Foundation Trust. And we've teamed up with Dr. Paul Chazot from the University of Durham to produce this lecture series. So it's a collaboration between Durham University and the NHS. And throughout this series, we've been trying to capture some of the key areas of research in pain management. And there are 5 lectures in this series. The first one was in October, and it was about the science of pain, and in particular about brain imaging. Tonight's lecture is about psychology. And in the new year, we have 3 exciting lectures still to come. The first of those is about complementary medicine, which has an emphasis on herbal medicine, or herb-related medication. The second is about pain relief drugs, so the cost and the effectiveness of those. And there might well be a comparison between what is done in the UK in comparison to Africa. And then the third lecture is about physiotherapy. It's about exercise and pain. We haven't got dates and times for those yet, but as soon as we do, we can let everybody know. All of our lectures are being recorded, and this one is no exception. And our first lecture can be viewed on YouTube. So if you go to YouTube and search for Durham University and the title of the lecture, then you should be able to find it and watch it. And we plan to do that with all of these lectures. This lecture tonight has been recognised by the Royal College of Anaesthetics. And they have awarded us 1 CPD point. And also, it is recognised by Learning and Development within our trust, which means that we are giving certificates of attendance out to people that attend the lecture. So if you would like to know about our future events for the lectures that are coming next year, or if you want a certificate of attendance, if you can make sure that you either write an email address or contact details on your feedback form or on the register. And we do take note of what you write on the feedback forms. From the first lecture, a lot of the feedback was that you really enjoyed the question and answer session. And tonight we have got quite an extensive question and answer session. And tonight as well, we have a panel of people that can answer your questions, which of course includes Professor Morley. Welcome to those of you that are from the general public, and we really have wanted to engage with our local communities. And the way in which we have done that is by doing a satellite session. So prior to the main lecture in the evening, we have gone out to various locations to explain about what is going to happen in the lecture in the evening. So before the first lecture, we went out to a local school in Durham, and we did an interactive session with 16 to 18-year-olds explaining the science of pain. And this afternoon, there's also been a satellite session. And I'm just going to invite my colleague to the stage just to find out exactly where that session was and what happened.
Hi everyone, I'm Mel Davis. I'm one of the clinical psychologists in the pain service based at the University Hospital of North Durham.
Okay. And where have you been this afternoon?
What we were hoping to do, as Joe said, is really engage with local communities in the region to really push forward our message about getting the message of chronic pain into the wider public domain. So we contacted a number of organisations, including CRUES, who I believe there's a few representatives from this evening as well. But this afternoon I actually attended the local mental health charity Mind, which is based in Darlington, and met with a number of the team there, a number of staff members, and also they invited some of their clients to attend the session as well.
And can I just ask how that afternoon went? Was it a good experience? What sort of things did you get up to?
Yes, it was well attended, and the group were very engaged in what we were discussing. And the idea was to keep it really interactive. So I came along with a few prepared materials, but really listened to the group to think about what they wanted to know more about. And we spent a lot of time looking at the link between physical experience of pain and the emotional impact of that pain. And through exploring that theory and getting some personal experiences, we also then had a bit of time in the workshop to think about techniques and tips and psychological sort of understanding of the psychology processes to enable people to take some take-home messages for both themselves and other people that they were working with. So we covered the issues such about how we get very worried when we're in pain, the sort of beliefs that we have in relation to the future, and what we can do to manage that anxiety. And we also talked about the impact on sleep and on communication and relationships, and again went through a few sort of strategies and coping strategies to help people manage in those different areas.
Thank you very much, Mel. And if you've got any questions for Mel, she's part of the panel at the end that will do the question and answer session. Thank you. Enjoy the lecture.
Thank you. Okay, well, I'm an academic for 4 days a week, but 1 day a week I potter along to my local hospital and work as a clinician. And my feelings about this alternate from week to week, as you might expect. Sometimes I think, oh no, how can I manage this? I feel I'd much rather go back and do something secure, like answer an email or write a paper, because I know I've got a difficult problem. And other weeks I think, oh yes, this is a difficult problem. What am I going to learn from it? And I fell into pain quite by accident. I fell into being a psychologist quite by accident, actually. I was really going to be a zoologist and study birds for the rest of my life, but something went off the rails. So I ended up studying pain, which is not where I expected to be many years ago. But for me, it's been a fascinating area to study. What happens is I see individual patients, and we also run a small pain clinic, and almost, not always, but almost invariably people with chronic pain are suffering both physically and emotionally. It's a bit of a killer. I'm often faced when they come to the psychology section, the first thing you have to do is to work out what they think is going to happen to them, why they think they've come. So that's really, what has psychology got to do with pain? And that's often a question you get asked directly or indirectly. Why? And obviously one of the thoughts that somebody might have is, actually, the doctor doesn't really believe that I've got pain. And not being believed that you have pain is a major theme. Comes through, and it's a very subtle, pernicious belief to have, if that undermines you. I'll talk about that a little later on. So maybe they're being referred because they really want to check out, using some clever psychological techniques like talking to people, whether they really have pain. Second question you get is, well, maybe they think I'm mad. And that's the way that some people even phrase it. So it's the kind of mad, bad, dangerous to know, get me out of the physician's clinic and get me into psychology. Is that why I'm here? Or are they just sending me because it's Last Chance Saloon? I think all of those questions probably pass through most patients' minds at some point during their contact with the health services. My stance is, and I do get asked, on the whole, it takes a lot to make me believe that somebody doesn't have pain. I really am not persuaded easily. So I will accept their explanation for what's happening to them. And also to point out that pain is a psychological experience. It's the long endpoint of many complicated bits of biology. But ultimately, what you feel and think is psychological. Doesn't matter what's going on in your neurobiology, your experience is what counts in this sense. So, what's the aim of the next 30 to 35 minutes? And I will disappear after that time. I'll try and keep it very to time. Well, I want to outline some of the themes in the psychology of pain. It's a mysterious subject, and I've written this lecture with the kind of idea in mind that most people in the audience are not psychologists. They may even be very skeptical about psychology, which is a very good position to hold, I might add. And just to run through and say, just give an outline of what I think is going on in the field at the moment. It's a very personal outline, but it's one that has helped me over the years. So a bit of history. Psychologists have got a long history messing around in pain, and starting, of course, 100 or more years ago with Freud, who, of course, was a neurobiologist, not a psychologist, but the idea that your conscious experience might be false, in the sense that it might be the consequence of other unconscious experience, but turned into something that was socially and personally more acceptable. So that's the kind of subtle bit of psychology, and it still lives around long in the services today. You still get that idea. Most people put that at the back of their minds, most professionals do. But it transformed into something called the pain-prone personality, which you still hear talked about. And psychologists for a number of years spent a lot of time doing personality tests, trying to work out whether they were. But it all proved to be a bit of a dead end, really, for all sorts of reasons. And it was based on clinical observations and biased samples. So I'm not going to go down that area. What I want to try and do is give you an outline of what's going on today when psychologists try and deal with this, not from the point of view of something that's abnormal, but what you see in front of you and what you experience is really just the consequence of normal behavior. It's what should happen. It's just that it's really unpleasant. So here we go. And what are we going to do? It's very simple, really. I think pain, the psychology of pain comes into three things. First thing that pain does to you is any pain that you have, and you've all had this, it interrupts you. It grabs your attention. And that's rather subtle. Immediately your attention is moved away from whatever you're doing, you focus on it, and then there's a whole cascade of thoughts and behaviors that happen as a consequence of that. But for most acute pain, that interruption really doesn't count much. It doesn't bother you. If it persists, if the pain persists, it does more than interrupt you. What it does, it starts to interfere. In other words, it stops you doing the things that you want to do, either completely or to the standard that you think you ought to do them at. Or sometimes more importantly, the standard that you think other people think that you ought to do them. Because we've already now, as soon as it comes into this field, your pain, by your behavior, becomes public property. So things can happen. Again, in the short term, over a matter of a week or two, interference doesn't really matter. We even have things called sick leave. So they allow you to take time off and rest. And you're allowed to enter roles which allow you not to do things where you don't have to engage in your normal activity. But if it persists and carries on, then it does more things. Not only that, interferes, it starts to affect your identity. That's the sense of who you are, and very often, more importantly, what you might become, or what you're afraid of becoming. Now, I've presented this as a cascade, but actually if you've got chronic pain, all of this is going on at once. You're getting the interruption, you're getting interference, and you're getting deeper things happening to yourself. And I want to try and illustrate each of these eyes, but a fundamental thing behind all of this, and something which I think psychologists have just strangely rediscovered, is the idea of conflict. What if you just imagine, if we anthropomorphize pain for a moment, what happens is pain comes along and sticks its hands up, and metaphorically it says to you, pay attention to me or get on with the rest of your life. That's the choice. And the interesting thing, of course, is that pain occurs always in the context of you doing things, being engaged in other goals and activities. And you can see that conflict happening, interruption, interference, and identity all the time. And it's only in the last few years, literally the last 5 years, that the psychologists I work with and think with have started to think about this, both in terms of how we deal with it clinically, but also how we investigate it experimentally. So let's have a look at interruption. Let me see what goes on. I've got little song tags in there, always something there to remind you. So there you are, interruption. I don't have prizes for knowing who wrote that. So you're sitting quietly in the lab, and you've got a screen in front of you here. I don't know whether this pointer works, and it's got a little blue sign that can come up, and those are your two hands, and on your right hand underneath it there's a little button that you can press. And I say to you, when the blue light comes on, I just want you to press a button, which is the simple signal and response. And you can do that, and reaction times, 300 milliseconds, anywhere above 150. But if you're kind of taking it leisurely, it's like that. So you're pressing that, and then I decide to give you just a little stimulus. It can be either a little laser stimulus or a little bit of electricity. And the one thing that happens is that your response is interrupted. Depends exactly where I put that little pain, but it will interrupt your flow of response. And it's quite resistant. It really does happen very, very easily. So in this one, your response gets delayed. I can get it, do another few things. I can actually give you a warning signal and then follow that by a shock. In psychology, that's just classical conditioning, pairing of two bits of information. But if I then put the warning signal on its own, that too will now produce the interruption. This very simple paradigm has been used a lot to explore what features of pain cause this behavioral interruption. And it's quite clear that, as you would expect, if something is surprising, the more intense it is. If it's novel, so you change the stimulus from one level of electric shock to another one, all these things will produce a greater interruption. What's been very difficult to do in this task, so these are properties of the stimulus, but the task that we're doing is trivial. What's very difficult to do, and I don't do these studies, but I know people who do, is to find another task that also prevents the interruption. It's very difficult to get a more difficult task that is not susceptible to interruption. So the task value, the only ones that we kind of know of, come from anecdotal studies. And that is where the task has a much higher value than the pain. And that tends to be when the task itself is an aversive thing, like running for your life. It takes a lot of doing something else for it not to be interrupted by pain. Similarly, the other ones where you do find that people are highly engaged in arousing activities. So I don't know whether you watch rugby football, but it looks to me horrendous. I used to play as a kid, but I wouldn't now. So highly engaged activity, highly aroused, pain apparently doesn't interrupt, or it's ignored. So it's very difficult to find something where pain won't get hold of you. It's normal for pain to interrupt. So that's something about the stimulus characteristics. And by the way, we know that when we transfer this not to experimental studies, but to study a natural diary study, a few years ago we asked patients at the end of their lives who had cancer pain to keep a diary record of their ability to switch their attention off pain. We found the things that made it difficult for them were when the quality or the location of the pain changed. The novelty and surprisingness and intensity of the pain made it very, very difficult for them to disengage from the pain, which they could often do under other circumstances. There's something about the people, you as a person. So if you're afraid of pain, or if you are engaging in catastrophizing, of thinking of the awful consequences of it, or if you have an overwhelming desire to control pain, if that's very high on your agenda, then all of those things mean you're more likely to be disrupted by the pain. And there have been some recent studies in the last couple of months that have come out that have shown very clearly that if you set people up with the agenda to try and control pain in the laboratory, their disruption of their behavior is much greater than if they don't have that control agenda. And I'll show you a clinical equivalent in a minute or two. So one of the things then about pain is it is hardwired to interrupt you. It has subtle behavioral and cognitive effects. You can't get away from it. In a sense also, it's not that it interrupts, but you can't distract yourself from it. Not only can't you, once you've got engaged by it, that's not the problem. How do you get disengaged from it? And all those characteristics are mirrored. They make disengagement from pain very difficult. And just to go back to this idea of the more you want to control it, the more difficult it becomes. It's a bit like we also call something in psychology ironic control or ironic intention. So if I tell you the next thing, over the next 30 seconds, what I don't want you to think about is pink elephants, you're going to be thinking about pink elephants. Have I thought about this object that he's told me not to thought about? Have you? Are they not walking across the forefront of your visual space? I don't know, but that's the idea. The more you try not to do it, it pops into it. So, I'm sorry, I'm just going to step back one. These studies have been they started from a very simple base, but they're very powerful and they demonstrate this interruptive effect of pain. They haven't actually measured the pain or what people feel, but if we look at the experience of pain, mostly we think that pain has a sensory quality. That's whether it's a burning or a throbbing or a stabbing pain. We can think about it as having an intensity, and we often think about it as being a degree of unpleasantness. And there are all sorts of ways of measuring that. What's important here is that we can pull apart the intensity and the affect. They don't necessarily go together. And one of the ways that we might do it is if we use this idea of interruption and attention, can we use this experimentally and clinically to help people? So here's just an example. This is a slide of women going through childbirth. And if you ask them to focus on the pain, over the 4 phases, their pain rises. If you ask them to focus on their impending birth, say just report the sensory intensity of the pain, it rises as well. If now we have them measure the unpleasantness of the pain, then you get this response. So women focusing on the pain feel it as being more unpleasant and more distressing. Whereas those focusing on, so they're given the instruction, avoid this pain, try not to think about it, that's the thing. Whereas the other group now are asked to focus on the baby that's just about to be born, you get a remarkable difference. That study, simply separating out the affective quality of pain through your focusing of your attention, has been replicated in other cases as well. But it does offer us some hope about one way which we might help people to deal with pain, especially when it surges up, when it gets very difficult to manage. Not all the time, you can't distract yourself all the time from the pain, but just on particular occasions. Interference. Every move you make. If you have chronic pain, it literally is every move you make, or rather, every breath you take. It gets you. And I want to, the question here for psychologists is whether the interference that you experience, your ability to do or not do things, is related to the intensity of the pain. Because if it's only related to the intensity of the pain, then all we need to do therapeutically is to control the intensity of the pain. You just turn the knob down and everything else will turn down as well. Unfortunately, it's not like that. But fortunately for psychologists, it's not like that because we can get our hands dirty. And I want to give you two illustrations of two classes of event that control the behavior that you see of people with pain that isn't related to the intensity of the pain. I mentioned earlier, once you have pain and your face flinches, or you hold your back, or you take a stick, or you grimace, or you utter something, your experience is public property. People will read it, and they will react to it. And they react to it in all sorts of different ways. And the first example I have is to illustrate that the social environment can determine how much people will do. So this is a study run in the Netherlands, and they asked pain patients to walk at about 3 kilometers an hour, or 2.5 kilometers an hour, on a treadmill until they felt that they couldn't walk anymore. And they either did this alone in the lab or in the presence of their partner. And their partners had taken a test, or took a test later on, and one of the things that we've known about for some time is partners behave very differently. And one crude way of separating those is into partners who are very solicitous and apparently caring about their patient, their suffering spouse. And they will say, oh, don't do that, I'll do that. Careful not to do that. And be very protective. And there are others who just say, well, you know, he knows what he's doing, let him get on with it. And under these conditions, so we call them in jargon non-solicitous and solicitous spouses. So, here we go. So this is a non-solicitous on your own, but you have a non-solicitous spouse. On your own, a non-solicitous spouse, with your partner. And in this case, you just walk for about another half a minute. So if your partner's there. Now, in the other ones, where you've got these caring, loving partners who seem to be very nice, on your own, you walk just as well as the other person does on their own. You're walking for, what's that, about 12 and a half minutes. Put your spouse in the room and you walk far less. So we've managed to have a really nice little experimental control to show that the social situation that you're in determines what you do. Now, you might not find that surprising, but hang on, isn't the intensity of pain controlling your behavior? Well, apparently not. We did a study a few years ago in which we just simply asked patients, who do you tell when you have pain? what and when do you say? And we asked, we didn't actually ask, we asked them who, but then we gave them 4 groups of people. We asked them about their partner, their friends and family, and we asked them about the healthcare situation, and we asked them about strangers. And their reports of what they say in those 3 contexts vary hugely. Not necessarily in the way that you kind of imagine they would do. People don't like showing pain in the presence of strangers. I have a friend who's an evolutionary psychologist who can give a lovely explanation for that. They also, many of them don't like or try not to show a lot of pain in the presence of partners and families. And they give very interesting reasons. They don't want to be a burden. They don't want to be seen to be getting out of things that they feel they ought to do. They don't want a sense of personal shame. On the other hand, if you ask them what you do when you get to the pain clinic, they'll say, yeah, well, you know, this is the doctor's territory. He's just, or she is going to know that I have pain. That's their responsibility. Now, it's kind of interesting because I go into the clinic and my colleagues say to me, you know, I had this patient in and they were so complaining, they can't possibly have had that amount of pain. But the message is being delivered in that context to try and get it over. So there are subtle changes with the way that people do this. There are some other studies that show similar results. So the point here is the expression of pain, either through verbal complaint or through actually what you're doing, is partly a function of your social environment, who's around you. And that's really interesting because once we understand that, then we can think about building that into treatment. So many pain management programs will ask partners to come in and they will talk about how they manage pain and whether there are ways in which they can relate to their spouse that's perhaps more productive and get them to help them more. Sorry, I'm going to skip the bit which is the pain ratings, which don't really matter too much. Well, the other thing that might be between the intensity of the pain and what you do is what you believe. And we've known now for the last few years that what you believe about what you are going to do has a profound impact on what you do. So, let me illustrate this. The one is rather complicated, but imagine this. You have a pain injury, you have pain experience. If normally, in most circumstances, if you're not fearful about it, you will, like falling off your horse, you'll get back on the horse and you'll ride off into the sunset. You just carry on doing things. On the other hand, if you believe that what you're going to do, so if you hurt your back, if you believe that if you lean forward and if you get pain, that will be a sign that you're doing yourself more damage. And if you keep doing that, something terrible will happen to your back and your mind runs away with it. In fact, what you're going to end up is being paraplegic and you'll be lying alone in a terrible, dismal room with nobody around you in your last days. These are fantasies. They're real, strangely enough, real fantasies that real patients have. So if you believe this threatening, if you have this threatening interpretation about what you're going to do in the presence of pain, and it's very fearful, then you become very vigilant for this, but you also stop doing things. You stop being active. And that not being active leads eventually to a whole cluster of things that we see in the clinic. Very often not doing things makes you pretty miserable. This is known as the fear avoidance model, and we now know quite a lot about it. And here's just a little illustration of the clinic. The way that we approach this is just to treat it like a phobia. And for years we've known, well, everybody's known that if you're afraid of something, it's usually better to face up to it. So getting back on your horse when you fall off is a good idea. Similarly, we can use the same principles that have been used in mental health and helping people with phobias and fears for years. We can use them in pain treatment. So we get help somebody produce a hierarchy of what they fear, And then we gradually ask them to engage in activities that they fear. Now, in this study, you can take, these are 3 measures that we have. It's just one patient, make it easy, that we keep a baseline during an activity called graded activity, which we don't ask them to engage in activities that they're fearful, but they do something else. We have no changes in these key measures of how fearful people are. But as soon as we ask them to engage in a very planned and thoughtful way in activities that they have found frightening and fearful doing, we get a dramatic change in their fear. And we reverse the condition, so instead of having graded activity followed by this thing called exposure, if we do it the other way round, if we get to the exposure first, all the improvement happens with exposure. Nothing happens with the graded activity. Now, this is just an example from CASE, but we've now got case series and some randomized controlled trials that suggest this. So this is a highly selected group of patients, and it's about reducing the fear. So the crucial thing that we're challenging is their belief is that if I do this activity, harm will come to me, and that harm will be irreversible and terrible. Now, the crucial point here is separating out in chronic pain a distinction between the hurt that it causes and the harm that it causes. A great American psychologist called Bill Fordyce pointed this out about 40 years ago. It's just taken most of us a long time to sort this out. So it's not the hurt. We don't treat the hurt, but it's the belief about the harm that seems to be crucial in connecting you, the pain, and the activity. So identity, who are you? And for those of you with German, you can get the Bach quotation. So what is identity? It's your sense of who you are and what you might become. There have been lots of studies where people have asked patients in a very structured way, what's your experience of pain like? And this is just some stuff that comes out of people's heads. So they talk about feelings about their body, being alien, being old before their time. Really interesting things about what we call suspended identity. Actually, the real me is me before I had the pain. And some very interesting psychology happens on them, because you say, what would you like to be? And they say, I would like to be the person I was before I had the pain. But if the pain was 10 years ago, the chances of winding back the clock from being 40 to 30 is kind of 0. The sense of being trapped physically, socially, in every sense, having a trapped sense of who you are, it messes up your social relationships considerably. So it has very profound activities impact on people. Well, that's all very well. That's the kind of qualitative thing that any smart clinician can pick up through listening and talking to patients carefully. And you will do that. We've tried over the last few years just to understand this using some normal psychology, like everything else. And we've borrowed something from really developmental psychology. In the field of psychology, we've had thoughts about the self, how people construct their sense of self for many years. And one idea has been that you can talk about yourself as you are now, which in the jargon we call your actual self. But if you ask teenagers, what do you want to be? They will come up with a whole range of things and how they would like to improve, and that might be their ideal self. We could also call that their hoped-for self. They might also have views about other aspects of self. They might have a view about what they ought to be. A very strong sense of who you think, what you think other people think you ought to be. That can be pretty pernicious at times. But what we do know from other studies that if we think about, for example, just your actual self as you are now and what you hope to be, we can think about two crucial parts of this. One, the distance between you. And the idea is if you're close to where you want to be, you will, in the technical jargon, be a reasonably happy bunny. If you're a long way from it, then you're likely to feel a bit dejected. And there are plenty of studies that show that relationship. So the further you are from what you hope to be, the less satisfied, the more miserable you are. Now, there are some important things about this. These hoped-for selves are also known as behavioural guides. So what you hope you will guide what you will do. And there's plenty of evidence to show the relationship between your hopes and your behavioural activities. There's also something that we've thought about as being enmeshment, not necessarily how far or how close you are, but a sense of whether you feel trapped. So you can be a decent way off, but if you think that you can get there, it's not a problem. So when I was leaving Leeds today, I was a long way from Stockton. I travelled in hope, but my wife was concerned that the snow would come down. I think, Paul, you were slightly concerned that suddenly the A1 and the A19 would be dolloped on. And I would then, of course, not been able to get there. I would have been blocked by the snow, but if I was a pain patient, you're blocked by the pain. This sense of you can't be what you want to be because you're in pain. And we've called that enmeshment, and we've managed to show in a number of studies that it's that sense of being trapped that seems to be a kind of crucial aspect to it. That is the bit that relates between your pain and the kind of overall emotional experience that you're having. Actually, it looks as if what gets caught is important. So it's not that everything of yourself is caught, but if the bits are really important, if the bits of your hoped-for self have got really high value, if they're entrapped, then that's very difficult. So if you were a concert pianist and you get arthritis in your fingers, you are in deep trouble, and your sense of self is profoundly challenged. On the other hand, I suspect arthritis in your little toe wouldn't concern you one iota. This is the content of what real patients say is in their minds when you ask them about their actual selves. It's a really mixed bundle. It's a whole pile of things about, pain, some negative stuff, some really positive things that they feel about themselves. So it's a really messed up generic bundle. And if you ask anybody, you'll get that kind of flavour as well. Most people have a range of feelings and states that they will describe. On the other hand, if you ask them what you're afraid of becoming, the ones that pop out are things like getting worse, wheelchair, a walking stick, drug abuse, dependence, financial worries, a whole loss of work, deteriorating health, a whole range of things. The interesting thing about this, of course, is these things might happen to anybody, even if they don't have pain. So we've been kind of interested in the feared-for self a little bit more, thinking that actually, having this overriding sense of what you fear might happen, might be something that drives a lot of at least one sort of interesting behaviour that we see. So we just get people to ask about their fear-for selves, and we ask them that if you get close to your feared-for self, what you're trying to do all the time is escape from it. You're trying to push it away. That's what's happening. When people are trapped by pain, if you ask them the question, could I be like this, even if I didn't have pain? If they say no, then what it's telling you is all their fears are contingent on this relationship with pain. They think that these fears are only there because they have pain. Sometimes in the clinic, if you do this, and they sit and they pause, I remember very clearly one patient saying, I've never thought of it this way, but, I really could be a miserable old git. And that was his exact words. Even without pain, he said, I think I was before. And that was a light bulb moment for him, because he started to reconfigure his notion of what he was frightened of. But we think this is trying to keep, if you're in this sense of being trapped by what you fear, it does drive one particular sort of behaviour that we think is very important, that we see a lot. Some of my colleagues have suggested that one of the things that happens with people in chronic pain is that pain, well, pain is a problem, but what happens is they get into perseverating, trying to problem solve something that can't actually be solved at the moment, and actually doesn't look like the chance of being solved. So what happens is they worry, trying desperately to solve their problem of pain. They believe that the pain can be removed by some biomedical intervention, and very often the clinic, certainly when we get to, before they come to the psychology part of the clinic, even when they come to the just normal chronic pain clinic and they see my medical colleagues, they will have a large file. They will understandably have tried a bundle of medications and a bundle of other activity as well. And it's a sensible thing to do. It's this thing that we've been taught all of our lives, that there is a way of controlling pain. Ever since your mother picked you up and kissed you and stroked you when you fell over and banged your knee and stuck a sticking plaster on it, you've been given this a message. There's a relationship between pain and it can be cured. And of course it does. Your experience for most acute pain is it goes away. So it's reasonable to believe that you should be able to sort it out. And the more complicated the pain, the more complicated the solution, and the more you need specialist medical technology to do it. So you engage in a lot of problem solving. Sometimes it's rather perniciously known as doctor shopping. I think it's a rather rude way, but it's an idea. These people are doing this because they're desperate. They're trying to solve a problem that you can't solve. But you keep going around here. And of course, failing to solve a problem produces worry and distress and everything that you would expect to do. It just feeds in onto the cycle. So it makes you even more hypervigilant for your pain, even more desperate to solve it. So a negative feedback loop really makes it work. If you can solve it, then of course you can escape. Find a way of doing it. And I always do hope, like every patient, that there will come along a magic drug. I'm sure Paul's going to invent it, and boom, it'll go. I'm less sure than I like to say. Why concentrate on this? Well, one of the really interesting things is that this is problem-solving activity. So perhaps, if we just go back to the first thing, is that perhaps the problem is if pain's getting in the way of who you want to be, perhaps we ought to find ways of working around it. Perhaps it's not a question of turning the pain off. Perhaps it is this question of helping people think about what's important in their lives, what's valued, and other ways of engaging in those activities and meeting those needs. Or sometimes disengaging from them. Sometimes it's appropriate to disengage from activities that you can't pursue. I disengaged years ago from trying to be a musician. So we've been playing with, beginning to think about how people solve problems. So we give them pain patients examples. You can't read it. The problem they get is Frank couldn't play tennis anymore because his back pain. He felt that his friends in the tennis club might be avoiding him. It's upset Frank, as it's important for him to be sociable and a well-liked person. So the point about Frank playing tennis is, yes, sure, he enjoys the tennis, but it gets him something else that he wants. It gets him sociability and being well-liked. Two really important things for him. And he gets it in our jargon through playing tennis. So we think about what's in your head as being organised this way. This is Frank's hoped-for self. Being social is all part of Frank's hoped-for self. This is what he likes to be. But being engaged, getting down at this level, the doing level, the playing tennis, is what's blocked. So how can Frank get around this? So if you give people this problem to do, and you just ask them, what would you do next? What advice would you give to Frank? Well, Frank ought to go and get some medication, get some physio, go back and see his doctor. All of these are concentrating on trying to remove pain. And we just simply say, well, actually Frank did that, but it didn't work. What else could Frank do? So we're getting an idea about how much people will perseverate at trying to solve this bit of the insoluble problem. But they could do it another way. So that's increasing his, trying to sort out get rid of that block. They could do something else. You could say, well, I'm actually going to volunteer to serve behind the bar. Seems like a good idea. It's got me what I want. Problem solved. Next thing they could do is actually, he might say, I'm going to abandon being sociable. I'm going to advance my career, put all my efforts into being a banker, which looks like a kind of something he wouldn't want to be socially at the moment, but never mind, he's decided to do that, but he solved the problem. And it does actually look from our initial studies that this kind of, the closer you are to your sense of fear for self, the more you want to get rid of it, the more you engage in our tasks on this kind of problem-solving behavior. We know from certain psychological treatments, one particularly called ACT, one way of helping people is to help them switch, identify things that are really important, but still maintain their sense of self, even with the presence of pain. And I think that is probably the most important direction that a lot of treatment for pain is going at the moment. So, treatment. A brief word on treatments. We've got a bucket full of them. For the interruption level, the obvious things you can do are give people drugs, things like TENS. The SCS stands for spinal cord stimulation. I've talked about this thing called attention management. Think back to the women giving in childbirth. Mostly these things fall into two categories: trying to modulate the pain, turn down the intensity. Even if you turn it down, of course, but you don't turn it down completely, you may, if you've had chronic pain for a long time, we now know that a lot of your pain behavior and your ways of thinking are kind of independent of the pain intensity anyway. So you're going to need something else to help you sort that out. For interference, your behavior, what you do, well, we can do quite a lot. I have very skilled physiotherapy colleagues who can help people move in a better way. There are good OTs. We have CBT that really works at this level. Cognitive behavior therapy and pain management programs are really about helping people manage this interference and the tricks that they need to separate their behavior and their distress from the pain. And then for the identity, well, there's some forms of CBT do this, but this thing that many people are interested in called acceptance and commitment therapy, which is still, I have to say, untested, but it seems to me it's on the right grounds. So that's my quick overview of pain. It interrupts, it interferes, and it impacts on your identity. And it's horrible. But it's not hopeless. It's not entirely hopeless. So thank you for listening. These are colleagues that I've worked with over the years. So thank you very much.
I found it fast. Sorry, perhaps I'm Brendan Hodgson. I have what's known technically as a bad leg. I was really fascinated by an awful lot of it, well, all sorts of it. But there was one where you had 6. You started with 3 little diagrams. Thank you. You had 3 little diagrams which looked like a lot of musical notes followed by some very low notes. And then you put another 3, which was the order in which something was happening, but I didn't really understand what all the little...
Yes. It was a kind of simple graphical timeline. So
yes.
There's that just an event coming along, and I think, you know, you prepare these slides on your desktop and you think, is it big enough for the hall and will it work? And I don't think that the clarity was very good for you. But the idea, what you could see was just how the idea that the sequence of events that was happening, and then the crucial event was what happened to, in this case, just simply your behavior, which is pressing a button, and the relationship of that to a signal. And we can just show that how much pain disrupts that. That was all a vehicle for talking through that. So I think that was the one.
Well, you did something beforehand or after. For the first lot, you'd done it after, but then we got to move it. And the second one, my understanding was you did something, you warned them or did whatever.
Yes, if you. So if we just do this simple task of, if we pair the warning, if we give them a signal that says pain might happen, then that signal itself can be very disruptive. So you don't even have to experience the pain to have the disruption of it. But that's fairly just straightforward conditioning.
But if we think about what that means in real life, that if you are used to doing an activity and you experience pain after that, then just the thought of that activity might create tension in your body. You're almost predicting the pain even when it hasn't yet happened. It's such a powerful connection.
Could you expand on what the ACT therapy is?
Oh Lord. Yes. The full name is called Acceptance and Commitment Therapy. It's there are two ends to it, really. One, if you think about it very simply, it puts the question to you: how can you live the life that you want to, even in the presence of things that are aversive? And the answer it gives is based in a lot of psychology. But one of the important things about this is that is the way in which people use language and thoughts. And the fact that language has a function. Sometimes what we think to ourselves, we mistake for what we think is reality. So we act on our thoughts rather than what is out there. That's putting it in a very condensed form. If you really want to know, the argument goes back to a very famous discussion in the 1950s between Noam Chomsky, who was a linguist, and a guy called Fred Skinner, who most people have heard of, who was a behaviorist. And Chomsky had a view about language that was about the structure of language, and Skinner said, actually, language has a function. Let's think about how people learn language, what functions it produces. And I don't go into linguistics, but if the same arguments go on in linguistics, but that idea that Skinner had about what language does functionally has been taken and explored and expanded and experimented with. And that's the basis for this thing called ACT. But actually, if you do it, it gets you to do, it's a thing that gets you, doesn't talk to you, you do lots of exercises, things that sound like really bizarre exercises. So you can, for example, if there's material which is highly emotive, or you're acting on it, so the word pain might be for some people. Or if you say, famous example is if I say milk, what do you think about? Of course, it's that, unless you're kind of deeply averse to milk, then you just think of that nice, cool, white, creamy substance. But if you keep saying milk, 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 it drains the meaning out of it. And there are little experiments like that that you get to do with people about what's going on in their mind, just to illustrate the connection between their feelings and thoughts and their behavior. You know, it ain't necessarily so. Okay? And now tell me there's an ACT specialist in the room who's going to tell me that this is all codswallop. Yeah?
You said you borrow ideas from psychology.
Yeah.
I'm just wondering if there are any sort of differing principles between sort of the psychological pain and physical pain, and particularly in relation to sort of how you then advise sort of strategies for dealing with it? Because I guess the psychological pain, it kind of affects your thought processes.
Well, all pain. I mean, I don't make that distinction. I think that's the critical thing. So that if I kick you, that will cause you pain. If you cut yourself, that will cause you pain. That pain is what you're feeling. It doesn't matter how that arises in that sense. Psychological pain, very interesting, people do talk about psychological pain. But most people make a kind of experience. So the pain of having your heart broken is a painful experience, but it's not quite the same. So I wouldn't make that distinction, certainly wouldn't make it clinically. But all pain is a conscious experience, and then all the things that flow from it, the behaviour that comes from it. And it's all normal behaviour. Sorry, I've not answered your question very well, apart from saying it's not a question I can answer.
Hello. A very interesting lecture. My question is actually on hypnosis. I mean, is hypnosis, in terms of, does it actually work in terms of managing pain? And if it does, at what level does it interrupt, interfere, or is it one's identity affects?
Wow. Well, the short answer is that if it worked, loads of people would be using it very effectively. So obviously it doesn't work in the sense that it obliterates pain for once and all. But there are certainly trials, lots of studies that show short-term effects of hypnosis on distress and on pain experience. So it works it's going to work at the interruption level, that very kind of first stage kind of idea, the kind of attention to pain. Essentially, hypnosis is an attentional manipulation. So it's all about trying to focus your attention away from pain, or rather keep it engaged in other stuff. That's the way I would think about it.
One thing clinically as well, if you think about what Stephen was saying about us focusing on the problem, if we think about it in terms of a pain relief as being the solution to it, and we're very focused on that biomedical solution, there's something about taking the control away from us. There's something else that will solve my pain, something else that can be done to me that will treat my pain. And to some extent, and you could disagree with me here, but to some extent hypnosis might fit into that. Something's happening to me that will help. And really thinking about ACT and thinking about the other treatments that focus more on your own values, your own goals, your own identity, that's giving an ownership and an empowerment back to the individual, that they've made the difference in their life, they are managing their own pain. So it's got quite a different emphasis as to what message you're giving the person, I would say.
I mean, you've portrayed quite a positive outlook on basically these sorts of approaches to, okay, it's a biomedical approach, okay.
Yeah.
In terms of, you know, what's in your heart of hearts, I mean, do you think, I mean, this is where we should be focusing, you know? Should we basically ignore the biomedical approach?
No, certainly not. I mean, for years I used to go to talks, and I have a colleague who works at UC, Tony Dickinson, who's a very smart pharmacologist. And I was always in awe of Tony, because he was able to do beautiful PowerPoints with lovely slides showing this massive cascade of biological substances that I'd never heard of. And each one was a potential target for a treatment. And it took me time to realize, well, two things. One, the psychology of pain was no less complex. There was a kind of psychological and behavioral cascade of activities that was related to what you saw in the clinic, what people experienced, how we did treatment, and so on. And the other thing that struck me about the neurobiology of pain was that it was overdetermined. You know, if you want a simple alarm system, Why not build a simple alarm system? But evolution hasn't done that. We've got a biological system which is immensely complex because pain is so important. It has such an important signalling effect. Why wouldn't you over-engineer it? So if you cut one piece of the transmission, so it's a bit like the World Wide Web in that sense. If one satellite goes down, it doesn't matter, your emails will just go around another part. If one bit of the computer goes out, it doesn't matter, it's replicated, it'll go somewhere else. So it's trying to deal, so in a way, I feel that we're all dealing with this very complicated, overdetermined system. And it makes me suspicious to think that anybody's going to have one thing that will cure, especially chronic pain, just like that. The only thing I know is to become decerebrate, and that's kind of not really an option. So, I mean, that's, I don't know, you're a neurobiologist. I mean, what do you think about that?
Well, yeah, I mean, I agree. I think the thing about pain, it is a complex system, and it's been built as a complex system. So actually, we'll probably take a more complex approach, a more holistic approach, and that's sort of, I guess, where we're coming from in terms of this series. Really thinking about, the holistic approach may be the way forward. It's showing success rather than just one way or the other. And also, I mean, one aspect also within the central nervous system, we actually have an inbuilt pain-killing system already, designed within us. And my feeling, actually, of a lot of disease associated with CNS is, can we actually trigger our own systems to work more efficiently through psychological approaches or biomedical approaches? And that, I think that should be engaged more rather than from the outside and taking pills or whatever. We actually use our own system because it's actually designed to relieve pain.
Well, one of the things I find interesting is that both biologically and psychologically, and I find it increasingly difficult to separate the two in a Cartesian manner that we often think of it, but is that somebody can be in chronic pain and yet experience an acute pain which they then resolve and live with, and in effect have relief from.
Yeah. And if you do that and you cut your finger or you do something like that and you take an aspirin or an anti-inflammatory, it works for that.
Yes.
Yes, that's right. It's still a functioning pain system in that way. Yeah, that's right.
I don't actually agree with any numbers because you clearly said that psychological therapies help patients cope with pain. But are there any numbers, statistics saying that actually psychological therapies lead to decrease of the medication taken by the patients or the dose, or decrease the time of the recovery for the patients?
Yes, there are studies and there are trials. There are many randomized controlled trials of psychological treatments for pain. Most of these trials don't include good measure of drug use, or if they use the measure of drug use, it's difficult to get the data out. But, so in other words, to aggregate across all the trials. But for individual trials, there's certainly evidence that people reduce healthcare use and healthcare costs. So there are specifically papers on that. And one of the other paradoxes is that most of these treatments are not designed to reduce pain, and yet very often pain reduces. And that's kind of curious.
A comment we very often get back at the end of, say, a pain management program or a group treatment or even one-to-one therapy is, do you know what, my pain is actually no different, but I'm coping with it better. And that's enough for me just now to move on with the rest of my life. And that, for every individual, is different. That might mean I'm now talking to my partner, or I'm now able to re-engage in an activity that I previously thought I'd lost, or I've developed a new social network, or someone's listened and believed me. So it is fascinating.
There's also another way around that, thinking about it psychologically. How do you know what you feel? Well, one of the answers might be, what am I doing at the moment? How am I behaving? That must be a pretty good index of what I feel. It's not entirely like that, but there are certainly, going back, normal experiments in normal psychology to show that people use their own behavioural performance as an index of how they're feeling. Certainly within social psychology, we know that people will adopt attitudes after they've engaged in the behaviour that represent that attitude. So in other words, you think, what do I believe? Well, what do I do? And then you impute, you say, well, I believe that because it's concurrent with my behaviour. The same thing a little bit goes for feelings as well. Now, one of the interesting things about if you ask people how much pain they're experiencing, and I don't know of any studies that have done this, but I would be surprised if the same principle didn't work. One of the indexes you might do is, what am I doing, or what can I do? And you make a judgment about that, about what you're doing behaviourally. Now, if programs are working at getting people more active, then they've got more cues for actually thinking that they're experiencing less pain. They might actually be experiencing less pain for good biological reasons as well. Complicated subject.
So are there any questions? Okay, please. Brendan?
From a purely personal level, I empathised entirely when you were talking about the chronic pain and the acute pain, because Dr. Nair's been treating me for many years because of my chronic pain, lots of medication, trying to treat that. Then I got toothache. All this medication he gave me didn't touch it. I think, well, you know, I'm getting all this stuff. Why doesn't it get rid of me toothache? And then, of course, you take antibiotics. Toothache? What toothache? What? It's not as simple as that. But you know, from a purely personal point of view, having experienced both at the same time, you appreciate the difference. You've
Yeah.
Any further questions?
Just got a question about, you mentioned something about bringing relatives along or partners along, and I just wondered whether that generally is helpful as a sort of clinician to have relatives there, or does that kind of get in the way, or is it helpful, or does it depend?
Well, some programs do it, kind of build it in. There are particular protocols that you can use. So there's a colleague of mine called Frank Keefe in the States, and Frank has worked for many years, run lots of studies with people with osteoarthritis, rheumatoid arthritis, and more recently with cancer, people with cancer pain. Frank has a really good protocol about managing pain. It's a highly structured program. It's pretty effective. But he also has in that another protocol that uses the same, but then gets the partners involved and teaches them. And there's evidence that that gives them, certainly that gives them marginal gains. Within the cancer pain area, it's much better because then there's very often the partner is the major carer, and is very distressing, especially as it's end of life. And that's a really helpful program. So yes, the thing that's really interesting to me is that there's going to be critical about psychologists in the sense what we do, what you do. If you're one of my medical colleagues writes a prescription and they know what's in that tablet, it's gone through a pile of testing. What we don't do as psychologists is go to the literature and say there's a really good protocol there that's gone through a nice randomized control. We ought to use that. Every pain program makes up their own. And I think, why? You'd never get away with that we ought to be more honest and more thorough about and more rigorous about the way we implement things. But nobody else heard that unless you're a psychologist.
In the Durham Pain Unit, when we run our group programme, it has been something we've talked about before. But we have a 7-week programme, and in week 1 and in week 6 we invite partners along, and we invite not necessarily family members but any supporter. That could be a brother, a sister, a friend as well, a son or daughter. And the reason that we particularly invite them back in our 6th week is that's the week we focus on communication. And what Stephen was saying earlier about how we communicate our pain at home and how that can be different in a clinical setting versus a stranger setting. We explore all of those issues in the group together with partners and carers present, so that everybody's hearing the same information and can have those discussions. And often our clients that come in say that they found that really helpful to allow their partners to come in.
Please.
One more question. I work in an addiction service. We treat a lot of clients who come with pseudo pain. That's pseudo addiction. That's people who acquire dependency as a result of pain medication being prescribed. Now, once that's being treated, I've always felt the need to kind of assess that pain to see whether I still need to make an onward referral. I mean, have you got any idea in terms of brief scales that I can actually use in terms of clinical practice to do assessments in terms of that pain once the dependency has been treated? And at what point would I then make the referral onto a pain clinic?
Crumbs, you want to get that?
As a standard assessment tool, we use a brief pain inventory as a way of mapping the pain on the body, looking at the worst pain, the least pain, and then the impact of the pain on 7 different domains. But one of the interesting things that there's been a lot of work done at the moment in general practice in primary care is on how bothersome the pain is. We know that more than 20% of a population will suffer pain at any one time, but how much of that is bothersome, how much of that is pain that is disrupting them, that they're not coping with? Because a pain clinic only sees a small percentage of that, and a quite a skewed percentage. A lot of pain is well dealt with by other health practitioners or by the person themselves coping. So that's what we would use just as a start of, is a brief pain inventory, trying to understand what the person who is in front of us is meaning by pain, and also what it means, what it's stopping them from doing. Again, back to this function, business, both biological function and psychological function, and what it means to them, because sometimes having the pain enables them to have permission not to engage or some other social construct which is a lot more complex, hence your pseudo-addiction, because it enabled me to opt out, to take tablets, to have this experience which I otherwise wouldn't have had. I'm not sure that answers your question.
I guess it does, in terms of what assessment tool. From what I understand, it's inventory. You talked about the pain inventory?
Yes, the brief pain inventory. It was developed for patients with cancer in 1991. It's freely available on the web, developed by Professor Cleland, and if you acknowledge him in copyright, he normally allows the use of the short form quite freely.
There are also some scales on the British Pain Society's website, and especially if you want them in languages that aren't English. There are a number of alternatives there as well.
I suppose Stephen's lecture this evening's made me think in particular about how much of our assessment we're tapping into the interruption and the identity issues. That if it's just a case of the interruption, it might be that that's more manageable. But if you're getting into the bothersomeness of how much it's interrupting day-to-day activities, then also key questions about identity, which you can often pick up in belief systems as well, in that those kind of belief questions. If we can get those questions in earlier, we might be able to identify people that are struggling at different levels. So that taking that model further might be really clinically helpful.
Okay. Exhausted questions? I think that's a very interesting question this evening. If you agree, I'd like to thank the panel.